Welcome to The Explainer. Today we're going to completely demystify one of the absolute most fascinating and honestly, most misunderstood organs in the human body. We are talking about the thyroid gland. I want you to think of this little gland as your body's master metabolic engine and its ultimate thermostat. It dictates exactly how you use energy, how fast your heart beats, and even how you regulate your core body temperature.
Now, if you've ever felt just inexplicably exhausted, completely drained even after a solid 8 hours of sleep, or maybe on the flip side, you felt your heart racing while sitting perfectly still on the couch, well, this microscopic factory in your neck might actually be to blame. The stakes with this biological engine are incredibly high because when it's even just slightly off, your entire system feels the impact.
Okay, let's dive into this. Here is our roadmap for today. We'll start with the master metabolic engine, then cover running cold, running hot, the inflammation spectrum, and finally wrap up with nodules and structural issues.
Starting off with Section 1, the master metabolic engine. Let's understand the body's ultimate thermostat.
Before we can even begin to understand the diseases, we have to establish the baseline. We need to see exactly how your body maintains its perfect physiological Goldilocks zone. Not too hot, not too cold. And it all actually starts up in the brain, with something called the hypothalamic pituitary thyroid, or HPT axis. This is a super tightly calibrated neuroendocrine feedback loop. The hypothalamus releases TRH, telling the pituitary gland to release TSH, which is thyroid-stimulating hormone. TSH then effectively knocks on the door of the thyroid gland, telling it to produce its hormones, T4 and T3. And here is the true genius of it all. Those circulating T4 and T3 hormones exert a negative feedback loop right back on the brain. When there's enough hormone floating around in the blood, the brain simply stops sending the signal. It's a brilliant, completely self-regulating biological thermostat.
So zooming in on the thyroid gland itself, the cellular biosynthesis process is actually a highly complex four-step assembly line. First up, we've got active transport, where iodide is literally pulled into the cell by the NIS symporter. Second, apical efflux moves it into the follicular lumen via a specialized protein called pendrin. Third, and this is absolutely crucial, an enzyme known as TPO oxidizes that iodide and couples it to create the actual hormones T4 and T3. Finally, in step 4, those hormones are released into your bloodstream. Now, keep this in mind, T4 is essentially just a prohormone. It's basically the precursor to the highly active T3.
Which brings us to a really surprising fact. Did you know the thyroid gland itself only makes about 20% of your active T3? No way, right? The other 80% is actually converted from T4 way out in your peripheral tissues. This vital conversion is handled by enzymes called deiodinases. As we can see here, type 1 operates in the liver and kidney, type 2 is super important for providing local T3 to the brain and pituitary, and type 3 actually inactivates thyroid hormones to protect your tissues from getting too much. Your body is just constantly fine-tuning this local conversion. So what exactly happens when this intricate engine starts running too cold and gets sluggish?
That brings us to Section 2, running cold. What happens when the metabolic engine stalls? First, we've got to look at the demographics here because they are pretty striking. There's a massive 5 to 10 times female-to-male bias when it comes to thyroid disorders. Females actually make up roughly 85% of these cases. And interestingly enough, there are also some fascinating racial demographics at play here. Generalized hypothyroid affects roughly 5.1% of the white non-Hispanic population compared to just 1.7% in the black non-Hispanic population. This strongly suggests there are significant genetic or environmental susceptibilities going on behind the scenes.
When we talk about primary hypothyroidism, the absolute main culprit in iodine-sufficient regions of the world is Hashimoto's thyroiditis. This is an autoimmune condition. Essentially, your own immune system mistakenly views your thyroid factory as a threat and just starts attacking it. Diagnostically, we'll see an elevated TSH because remember, the brain is screaming for more hormone, but a low free T4, right alongside the presence of anti-TPO antibodies. The clinical result of all this? A totally stalled, sluggish state. We're talking profound fatigue, weight gain, cold intolerance, and even depression.
But as you know, medicine isn't always black and white. And this brings us to a major clinical gray area, subclinical hypothyroidism. This happens when a patient has a high TSH but a completely normal free T4. The massive dilemma here is that nearly 50% of these borderline cases actually resolve completely spontaneously. So the big question is, when do we actually step in and treat?
While the American Thyroid Association has some very specific guidelines to help navigate this,
Generally speaking, treatment is recommended if the TSH is 10 or higher on 2 separate assessments. If it's under 10, intervention might be considered if the patient has positive TPO antibodies or a high cardiovascular risk. Now, in pregnancy, immediate treatment is absolutely required to protect the baby's neurodevelopment. Interestingly, though, for patients over 65, data from the TRUST randomized trial showed that low-dose levothyroxine provided absolutely no improvement in symptoms or quality of life, which really adds some important nuance to how we manage older populations.
So, when treatment is actually needed, the standard go-to therapy is levothyroxine. That's a synthetic T4 that offers incredibly stable dosing. But you might also hear folks talk about desiccated thyroid extract, or DTE, like armor thyroid, which is actually derived from pigs or cows. When we compare these options, there is a totally critical biological mismatch you have to consider. Humans naturally have a 14-to-1 ratio of T4 to T3. Pigs, on the other hand, have a 4-to-1 ratio. Because of this, DTE contains much higher relative levels of active T3, which is exactly why it often carries a risk of inducing clinical thyrotoxicosis, basically giving the patient way too much hormone. But what about the exact opposite extreme?
Let's move to Section 3, running hot. This is when the engine is running at maximum RPM.
This wired, hot, tachycardic state of total excess hormone production is what we call hyperthyroidism, and the primary cause here is Graves' disease. In Graves, specific antibodies, called TRAB or TSI, essentially jam the on switch of the thyroid's TSH receptor, causing massive hormone overproduction. Diagnostically, the picture completely flips from what we saw earlier. We see a totally suppressed TSH, often less than 0.1, paired with elevated free T4 and T3. The symptoms are a drastic contrast to hypothyroidism too. Patients experience severe anxiety, insomnia, a constantly racing heart, and rapid, unexplained weight loss.
Because of those intense symptoms, management strategies have to be highly individualized. Beta blockers are usually the first step to give the patient some immediate relief from that racing heart. Then we have anti-thyroid drugs. Methimazole is generally the preferred choice here, but a drug called PTU has a very specific quirk. It's actually the required medication during the first trimester of pregnancy. Then there's radioactive iodine, or I-131, which selectively targets and destroys those overactive cells. And get this, because patients are literally radioactive for a bit after taking it, they require strict safety protocols. They have to follow things like the famous double flushing the toilet rule, just to protect their family members. Finally, surgical removal is always an option for a definitive, rapid fix.
Next up is Section 4, the inflammation spectrum. Let's look at leaking hormones and structural damage.
Now we're shifting gears from functional overactivity to physical inflammation, where the gland is actually leaking preformed hormones. And this brilliantly illustrates the different ways thyroid issues can manifest. We already talked about Hashimoto's, which typically leads to permanent hypothyroidism, but look at subacute thyroiditis. This one is usually post-viral, and it's uniquely characterized by a very painful thyroid gland. Then there's postpartum thyroiditis, which is also autoimmune but completely painless, and as the name implies, it happens after pregnancy.
What's really fascinating here is the timeline of destructive thyroiditis. It's actually completely self-correcting. From months 1 to 3, patients enter a thyrotoxic phase. Inflammatory damage causes stored hormones to just leak right out into the blood. Now, antithyroid drugs are totally useless here because the factory isn't overproducing, right? It's just spilling its existing inventory. Then, by months 3 to 9, that hormone pool is completely depleted, triggering a hypothyroid phase while the cells scramble to repair themselves. Finally, by months 12 to 18, 80 to 95% of patients return to a normal euthyroid baseline. Nature is amazing like that. But what about the physical architecture of the gland itself?
Let's cover our final section, Section 5, nodules and structural issues. The bumps on the assembly line.
68%. Honestly, this is a shocking statistic. Up to 68% of patients have thyroid nodules detected when they're scanned with high-resolution ultrasound. Think about that. If you scan everyone walking down the street right now, more than half would have a little bump on their metabolic assembly line. But let me quickly reassure you, approximately 95% of these are completely benign. No need to panic.
So how do we deal with the remaining 5% without just over-biopsying every single tiny bump we find? Well, modern medicine uses something called the ACR-TIRADS classification. It's a highly structured, points-based ultrasound scoring system. Radiologists closely examine the nodule's shape, its margins, its density, and they assign points to safely stratify the risk of malignancy.
It's how they determine exactly who actually needs a needle biopsy and who is good to go.
Which leaves us with this final thought for today. Your thyroid gland weighs less than a single ounce, yet it governs your heart rate, your brain development, and your core temperature. It perfectly regulates a biological Goldilocks zone every single second of your life. So if an organ this tiny holds that much power over your human experience, what other delicate balances are quietly keeping you alive right now? Thank you so much for exploring the master metabolic engine with me. Keep learning and keep asking questions.